what an honor to be able to be back here. I'm from Central Florida. I used to live in Tennessee, but I currently live in Orlando, Florida. I'm a friend of Mickey Mouse's, and my wife works at Disney. I'm a favorite aunt and favorite uncle of many of our nieces and nephews because we can take them to Disney, as you might imagine. But what an honor and what a blessing it was to be able to drive across the mountains of Tennessee to see the colors. I know you're not fully there yet, but man, I came across the Goose Gap Road or something like that, and I thought I was going to touch my back end going around those corners because I haven't been in curves like that in years. So it's beautiful to be here, and what a great conference. So my presentation today may be a little bit more granular, a little bit more clinical, and I will disclose I do work for ResMed. As Candy said, I'm a clinical specialist, but I'm a clinician first. I have the opportunity to do our internal training at ResMed, so I work with all of our sales teams, all of our clinical teams, and do internal training. So this is a passion for mine, and I hope that comes across today. So I have 3 simple objectives. One of the things you learn often as a trainer is that you have to provide clarity and get to the point. So I don't have 50 slides, I only have 49. So we'll be okay. But we're going to talk a little bit about respiratory physiology. Let me just ask, in this room, is there anybody that has less than 5 years experience as a sleep tech? Not a single person. Oh, one person over here. Wow. So it's interesting. So a lot of this will maybe very familiar to you, but I hope today there'll be some new concepts for you. How many folks in here are dual credentialed? How many folks have sleep and respiratory background? So a handful. Okay. So I was a respiratory therapist first, and then had the opportunity to go into the hospital and open a sleep lab in a hospital in Hot Springs, Arkansas, which is where I'm from, and which is why I have the accent, even though I live in Florida. So we're going to talk a little bit about physiology. Again, maybe some of it might be new to many of you. It might just be a refresher. But also we want to talk about patient assessment. I personally think that along the patient's care continuum, you're going to have longer to spend time with that patient than anyone else that's going to touch them. The doctor's not going to spend that much time with them. The DME is not going to spend that much time with them. You're going to have them captive for a period of time. And I think it's us as sleep technologists that are going to be the driving force behind how we treat that patient, what devices we treat that patient on, and ultimately their experience if they're diagnosed with sleep disordered breathing. And that could be OSA, CSA, that could be comorbid conditions, which we're going to talk about. And then I really want to focus on making sure that that patient is on the right therapy and the right device, and I would like to see that happen more in our hands as sleep professionals, and have that less determined when that patient fails at home 3 months later. Would you agree? So, a bit of a brain break, if you will. I have a new manager that started. She's great in instructional design. She's never been in a sleep lab before until last week. She went to Oklahoma. She's in Tulsa. A 12-bed lab. They have 2 tech rooms. The first room she went in, there was 4 techs in there. They got everybody hooked up, so she was able to see 1020. She was able to see them all hook up, get to bed. Nothing happening. She went to the next room, 4 techs, conspiracy theories. One patient had ripped off everything they'd put on and stormed out the door, and I said, "Welcome to the sleep lab." Because that's the way it happens, right? Some nights are okay and some nights aren't. So I do want to say as we start, I mean, you guys are on the front lines, and so I appreciate you, and I know that you guys help patients sleep better, breathe better, and live better lives as a result of what you do. So thank you. So I like to talk about lung mechanics, and I like to use props. I like to use balloons. Anybody, and I don't know if you can tell from back there, anybody guess right or left which balloon has had more air blown in it? Absolutely. How can you tell that? it's stretched out, right? That same thing happens to the lungs. I have blown much more air into this balloon than I have this one. This one's brand new, right? But if I hold this balloon and I pinch off the top, I can get some air in there. But, and my wife hates this because I laugh at that noise. She doesn't. She doesn't think the fart noises are funny. I still do, sorry. But if I don't restrict that, and I blow into it, I blow it up much quicker, right? It's the same theory about our lungs, right? Anything that causes restrictions in our lungs means our lungs are going to be difficult to fill with air, right? Anything that, let's say someone has obesity hyperventilation syndrome, and I blow up that balloon, and now I have all this compression pushing up on my lung. Can I expand my lung as much as I need to? No way, right? I don't know if that little demonstration, I like visual stuff. I'm a visual learner. It helps me to remember those are the things that our patients are experiencing. Their lungs, if they have less elasticity in their lungs, if they can't recoil as much as they used to, if it's resistant, which would be the case maybe of a neuromuscular disease patient, then all of those factors are things we have to consider when we're treating that patient at night. I'm going to talk about 3 of the most common things we might see in the lab, right? Which is COPD. COPD is an umbrella term for patients that have chronic bronchitis. So what are some of the characteristics of bronchitis? Well, you can see one of those on the screen. They have restricted airways because they have a lot of junk in their airways they can't get up, right? Because here's where I'm going with this, and I hope it's obvious. We treat up here with EPAP or CPAP, but it doesn't do anything for the rest of the lungs. I think we're going to see, and I think we already are, seeing more challenging patients in our lab. The easy patients are being done by HST. We're seeing the complex patients. So we have to keep all of this in mind, right? What do we expect from those patients? Those patients are going to have an increased work of breathing. Those are going to be the patients that we see that someone talked about earlier that come into the lab, or I think Dr. Sam talked about. They already have an elevated respiratory rate. We don't want to add to that, right? We want to try to relieve that. We can't necessarily do that by just treating the upper airway. We're going to have to think about more complex ways to treat those patients. Patients that have neuromuscular disease, right? They have restrictive disease. Again, can't get the air in as much. Those patients like a real long inspiratory time. Whereas patients that have COPD want to get that air out of there because they've already got too much air in their lungs. Because just like this balloon, when those patients exhale with COPD, they don't go from flat. They got this much air left in their lungs. So they can't get that much air left. And all of that air is down at the end of the airways, and this is what's called auto PEEP. So auto PEEP, this is a visualization of it, is air left in that patient's lung where you or I have the ability to let it all out, right? So they don't have as much functional residual capacity in their lungs because it's all trapped. Their airways are damaged. So we got to keep that in mind when we're treating these patients. The other thing that we see a lot of, unfortunately, is folks that like me, like to eat. Or they may have some condition that's caused this, right? But they have obesity hyperventilation syndrome, and that's defined when someone has a greater than 30 kilograms per meter squared BMI. So once you get up a BMI, and now they've graded it, the worse, the higher the grade, the higher the patient's BMI is. And again, this is a restrictive disorder. So these patients struggle. And it's interesting. I'm going to admit, again, I was a respiratory therapist first before I was a sleep tech. So I hope I don't offend my respiratory friends in here. But I thought I knew everything about sleep. But I didn't. No idea, right? I'd never seen an EEG before. I'd never watched a patient sleep all night before. I was a critical care respiratory therapist that took care of an emergency situation right now, right? What I didn't see was those patients coming in, and I could fix their upper airways. And you don't have to show me your hands with this, but I'm sure you've seen this. You fix their upper airways, but what does their O2 sat still do? It's just, boom, low all night long, right? And you're sitting there thinking, well, what can I do to help this patient? Maybe you have protocols in the lab that say, well, I need to add oxygen, right? But will adding oxygen fix that patient if they have obesity hypoventilation syndrome? Will it fix the underlying cause? Absolutely not. Will it maybe increase their oxygen level? Yes. But it won't ultimately fix their problem, right? So, ooh, gosh, I'm so sorry. Everybody awake now? So that's what you do when you have the last session of the day. You just do that. So there's some normal changes that happen during sleep. And this is something that I have to remind myself of. You and I, we inhale, we exhale, we don't give it much thought if we have normal lungs. Inhale, exhale. But someone that has diseased lungs, these things are multiplied. These happen to us with normal lungs. Minute ventilation is a term that means if we're breathing 20 times a minute and each breath we're taking in 500 cc's of air, that's what minute ventilation is. So it's respiratory rate divided by tidal volume, which is the amount of air we take with one breath. That's what minute ventilation is. Our minute ventilation normally decreases when we sleep. And we see that because we see patients that are transitioning from wake to sleep, and what do? Their respiratory rate waxes and wanes, and it changes, right? And that means that they're changing their minute ventilation too. For a patient who has compromised lungs, guess what's that do? That's further compromising them, right? So the other thing that happens is we have a natural increase in our CO2 level. And that's because of this change in minute ventilation, our CO2 will naturally go up. What happens, what do we see with a CO2 patient? A COPD patient, what's their CO2? Is it elevated or is it normal? It's elevated, yep. So this adding to an already elevated CO2, just normal changes with sleep. The third thing we see, right, is a decreased ventilatory response. We think of REM, right? I think of REM. What happens during REM? What's active during REM? Not much, except our diaphragm, right? Thank goodness for our diaphragm. Oh, but think about the obesity hypoventilation syndrome patient I just mentioned. What's compromised with these patients? So imagine again, they already have decreased ventilatory response. They can't move their diaphragm normally like they'd like to because they may be laying supine and the weight's pushing up on them, right? And again, we can treat up here, but ultimately we got to start thinking lower than here. And that's what I'm asking you to do today. And then the fourth thing, right, is that respiratory rate. Back to that, respiratory rate changes. It changes as we go through various stages of sleep. So patient assessment. Now, this may seem rudimentary because I know a lot of you, we're reviewing charts. But back to that comment I made a minute ago is that oftentimes you're going to know more about that patient than anyone else along the route. So I want you to keep these things in mind, right? When you're reviewing their medical records, make sure, do you know if they have a comorbid disease? I'm sure you do, but think about, okay, what might I see? How might this patient present if they have COPD, neuromuscular disease, right? How might that affect them? And then, obviously, there's some patients who have central sleep apnea. Some of those patients, right, we have to have some testing for those patients. So that type, we might need testing, like we need to make sure that their left ventricular ejection fraction is greater than 45%, right? Now, I will say this and caveat it. I don't think these are patients that these aren't patients we split that I'm talking about today, right? These are complex patients. But let me ask, how many of you do maybe 2 to 3 ASV studies per month? Anybody do 2 to 3? 1? An occasional? Sorry? Once a year, really? Wow. Okay. Are these things that you look for in medical records already? Are these things that you're looking for on a regular basis? Are you looking at, do they have any other history, comorbid diseases? Are you looking to see if they've been on PAP before? Right? That might be an indicator that they might need a more complex device to treat them. And this last one is a big one in my mind. That's education. Again, we talked earlier about how patients are receiving PAPs at their doors. Some of them are being dropped off. Others are being shipped to patients' homes. And so the challenge is, where do they get that education from? They're not getting it unless, I hate to say this, while you're sitting there hooking them up, right? And you have that few minutes with them, that may be the most anybody explains to them about OSA. So patient education is huge. It's a huge, huge barrier to compliance. It's a huge barrier to those patients once they get home if it's not something that's done on a regular basis. So this may seem a little redundant, and it is. But I really want to point this out because I'm going to talk about some types of devices in my next few slides. And I want this to really stick out for you. If a patient has hypoventilation or hypoxemia, it's critical to know those things. I have a colleague that likes to talk about additional vital signs, right? When we think of vital signs, we think of heart rate, blood pressure, temperature, whatever, right? So, but I think in the sleep lab, does anybody in here use CO2 monitoring in your labs? No one. One? Do you use it for just pediatrics or adults? You use it for adults, okay. That's another vital sign in the lab. It's cost prohibitive, which is why a lot of labs don't have it. It's not cheap to do it, quite frankly. But it's an important factor. And again, back to my earlier comment, and I saw a lot of head shaking, we're seeing more complex patients in our labs. So we're going to see these types of patients that we probably need to assess. The other thing is that tidal volume that I talked about a minute ago. Depending on what type of equipment that you have, that should be something that you have the ability to see. You should be able to see what someone's tidal volume is with each breath. Not just the breaths that, they're, and you can see them obviously if they're on treatment, you can see them as well. But you should be able to see their spontaneous volumes. And why is that important? I don't know why it's doing that, I'm sorry. Why that's important is because everyone has a predicted tidal volume. It's based on your height. It's not based on weight. Weight is not an indicator. It is based on your height and based on whether you're a male or female. This comes from the National Institutes of Health. It's free. You can download it offline, which is where I got this. But it's my opinion as a clinician and someone who's been deeply involved in looking at more complex patients, that this is a huge indicator of how your night's going to go if that patient has COPD, neuromuscular disease, or obesity hypoventilation syndrome. If they're less than this normal by 20% or so, you're going to have a long night. Again, you may be able to fix their upper airway issues, but you may not be able to completely solve that patient's issues. And again, my concern is once that patient goes home and they get put on a therapy that might not be exactly right for them, and they drop off therapy within 6 months, we haven't really accomplished our goal as clinicians, what we want to do. So this is where we come in as sleep professionals. I heard a very interesting statistic. I don't think this will surprise anybody, and it's probably not the split at your labs necessarily, but if you took 100 patients that were being studied, 65% of those patients would be being studied on a home sleep apnea test or an HST. 35% of those patients would be in lab. Does that number shock anybody? 65% of patients are being treated with an auto set at home. And they haven't been in front of someone like yourself who is a professional and may be able to determine whether that's the right therapy or not. Now, we don't have a lot of control over that because a lot of that is insurance driven, and so it's out of our hands, right? Which is why our DME partners are so important, because hopefully they'll catch whatever issues might be happening and then drive them back into the lab, because that's really what that should look like. But I see the head shaking. That's probably not what's happening. So again, that 35%, in my estimation, those are not simple patients. If they're coming to your labs, they are complex. So we should keep that in mind. So when you do the test, and that, oh, stay in between. I'm so sorry. I'm going to go over here. Forgive me for the folks that are at home as well. I heard there was about 100 folks listening to the doc's message earlier. So 100 folks online. That's pretty cool. But when they come into our lab and we have a chance to do them with an attended sleep study or a PSG, we've got a lot going on, right? We have a lot of decisions. So that's what this is, a decision tree. Those decisions are, if that patient does have OSA, then maybe they go to APAP, or we treat them on CPAP and we titrate them, right? But if we notice that they're having a lower than expected O2 sat during that study, again, it may be, you know what, we need to maybe think about that patient. Maybe they have some type of hypoventilation issues going on, and we need to assess for that. Or again, if they do have centrals, and it sounds like you guys don't see a lot of patients that might fit into that, maybe those patients might be considered for ASV, or they may need to come back in and be reevaluated. Excuse me. So let's talk about treatment for these patients and what we can or can't do, honestly, or what we should or shouldn't do. And again, rudimentary is it bilevels, 2 pressures. But there are a lot of devices that are bilevel devices, right? There's bilevel that's just a straight bilevel, IPAP over EPAP. We'll talk about who we treat with those patients. There's bilevel devices with backup rates. There's ASV. ASV is a bilevel device. Then there's volume assured pressure support modes. Anybody do volume assured pressure support titrations? VAPS titrations. Okay, we'll talk about those. So I like this slide. Again, it's rudimentary, but it helps me as a clinician to remember what do these different various settings do. What exactly is happening when we adjust these, right? We know that EPAP is what's maintaining that patient's upper airway, right? It's keeping them open, but it also helps to improve their oxygenation. Again, we do have to watch, though, because if that patient is COPD, remember the balloon and all the air trapped in the bottom? We can sometimes make that worse. We still have to treat the airway regardless, but it can cause other issues because they already have air that they can't get out of their lungs as a result of their disease process. So IPAP is what we add, and what's that minimum level of pressure difference between IPAP and EPAP? It's 4, right? And I want to talk about that in a minute. Because what IPAP does is give that patient a volume of air. So anytime you increase IPAP, so if you're increasing IPAP by 1 centimeter, you're giving them about an additional 50 cc's of volume, back to that tidal volume. So keep that in mind. Every centimeter that you increase, you are increasing that patient's ability to get a bigger volume and a better breath. Again, not asking for a show of hands, but most of the labs I go into, when they titrate a bilevel device, they always leave that difference at 4. They never ever consider, once they go up on EPAP, going up on IPAP. But yet that patient is still struggling and they're not getting a deep enough volume of air and their O2 sat's still struggling. You don't have to leave it at 4. 4 is required by the American Academy of Sleep Medicine to call it a bilevel device. But you don't got to leave it at 4 unless your policies, let me back and say this, right? If your sleep lab policies don't align with that, then by all means, leave it wherever your sleep lab director tells you. But I want to tell you as a clinician, you can make a difference in that patient by simply increasing that IPAP. If they have one of these disease processes, give them more IPAP, give them more volume, help them out. They're struggling to breathe. And then a lot of devices, and we talked about that, the difference between IPAP and EPAP is pressure support, and that's what reduces CO2 as well. Not only does it give them more volume, but when you have more volume, you blow off more CO2. And then a lot of devices, and this is something you'll have to determine yourself, right? But there's what's called, in some devices, especially in a bilevel, you're not going to see these in a CPAP, but there's trigger. And trigger determines how easy is it for that patient to transition from EPAP to IPAP. That's what trigger is. And rise time is that boom, that time it takes between EPAP and IPAP, that's what rise time is. So, if I have a neuromuscular patient that's struggling to initiate a breath, should I make that trigger more sensitive, or should I make it easier for them to transition? I should, and I can. It's a simple adjustment. You don't need a doctor's order to do that. You're a clinician. You just need the training and the comfort to be able to say, I can make a difference, I can do that. And if you don't have that comfort level, by all means, reach out to whoever you're working with and have them help you talk through what these are. I'll just give you a little tip. And again, this is, I want to stay this completely vanilla, right? I'm not one manufacturer or another. That's not the point of today. But check with your manufacturers to see what type of guides they have to help you understand how to adjust these settings. They're very simple, and they all have them. And it very clearly calls it out. If your patient is having a hard time, go here. If it's too easy and it's what's called auto-triggering, meaning that they're not even taking a breath, but it's giving them one. Have you ever seen that happen? That's because the trigger's too sensitive. Did you know you can back off of that and change your night and theirs, right? But you can change your night. And then cycle is huge. Remember, what did I say about a COPD patient? Do they like to keep air in their lungs a long time? Absolutely not. You can change their night, and yours too, by simply changing that cycle time, making it easier for them to exhale and not staying in that phase so that they feel like they're just blowing up like that balloon and never letting any air out of their lungs. So a normal breath cycle, we exhale about twice as long as we inhale. And there's also some devices that have what's called inspiratory time, and they have inspiratory time minimum and inspiratory time maximum, and I'll talk about those in just a few minutes. So these are some patients, again, that might benefit from just a bilevel with the IPAP over EPAP. Those are patients that are on high pressures. Again, not my rules. American Academy of Sleep Medicine says that if you reach a pressure of 15 during a titration, that's when you should consider moving to a bilevel device, right? Jerry talked earlier about a patient being on 28 over whatever. I can't even imagine that patient even stayed on that device. I probably didn't, you know. They were blowing up bigger than that balloon I blew up a minute ago. The other patients that sometimes benefit from that are those patients that have COPD but also have upper airway obstruction, and they coexist. It's a term called overlap syndrome. It means they have both. It means they have an obstructive airway, it means they have COPD, and those patients can be treated as well with just a spontaneous bilevel. Some people use bilevel that have the ability to have the auto EPAP so that it can titrate that patient in the home care environment. So, how many of you were in with the docs session just a few minutes ago at lunch? A few of you? So I'm gonna further define phenotype because I had to look it up myself when I first started hearing about it. Maybe you all are experts and know this. But a phenotype, all that means, it just means that it's observable characteristics that are similar across the same patient types. Anybody in here have a small dog? Anybody in here ever ran into a Dachshund on your walk? Do they think they're small dogs? I don't have a Dachshund anymore. I had one. They think they're Rottweilers. Every Dachshund I've ever ran into thinks they're a Rottweiler. That's phenotype. It's as simple as that. That's what phenotyping is. It just means a set of observable characteristics. So this was a large study that was done by Dr. Pepin. It was published in 2021, so it's a more recent study. And they looked at 480 patients that fit into these quote-unquote phenotypes. Hypertension, diabetes, COPD. And they looked at their termination rates with therapy. And how likely were they to terminate therapy? And so you can see, I won't read all these to you, but termination rates as far as out as year 3, 48% of those patients that were in those observable set of characteristics had discontinued therapy. Now, in my mind, those 3 groups of patients need to be on therapy 100% of the time, right? We don't need to lose 48% of them. And why did we lose them? Is it possible that we weren't meeting all of their needs on just CPAP? It's possible. Which again is where I'm asking you guys to think. Think beyond fixing the upper airway. You're clinicians, you are experts in your field, but look at these patients overall, overarching, if you will, issues, and think about that. Jerry talked about it earlier. A lot of times the doctors are looking at the studies that you scored and taking your recommendation as to what that patient needs. I don't know if you feel comfortable doing that or not. I haven't always done that. I haven't always felt comfortable with that. Just to be perfectly honest with you, right? And you know your medical director whether you could do that or not do that, right? But a lot of that has to do with the relationship that we develop. But these are the types of studies, though, that are important to kind of say, these are the things that are happening. So, I know there's not a lot of folks that use ASV, but this is a soapbox for me, so I'll warn you ahead of time. I'll try not to stand on it too long, I promise. ASV is one of those therapies that is misunderstood. And as a clinician, because we don't do it very often, I found that it can be intimidating to some, especially newer technicians or technicians that don't do it very often. So there are 3 subsets of patients that we see that have or may be treated with ASV. Those patients are patients that have treatment emergent central sleep apnea, or those are patients who we fix their obstructive events, right? And what do? Doggone it. I know you've seen it. What happens? After you fix their obstructives, what starts to happen at 2 a.m., 3 a.m. in the morning? They start to have centrals. What do you do to try to solve that? Or you maybe back off on the pressure to see if darn. You know why that happens, right? Because these patients have had abnormal breathing, like we talked about in that earlier slide. And so this is what causes central sleep apnea. Again, you guys probably know this. but it's all CO2 driven, right? We breathe because of CO2, not because of oxygen. CO2 is the driver behind why we breathe. So we've got to get rid of CO2, but if we don't have enough CO2, guess what our body says? I don't even need to breathe. I feel pretty darn good. So I'll just stop. Silence is uncomfortable, isn't it? So is central apnea, darn it. And we got to fix that. How do we fix that? We fix that by stabilizing that patient's breathing. So ASV, the goal of ASV is to stabilize patients' breathing. It will not support their breathing. So if they have treatment-emergent central sleep apnea, patients that are on prescribed pain medications will have 75% of patients. So if you see that patient's on opioids when you're reviewing that chart, Katie bar the door, be ready to look for central sleep apnea during the night because that's probably what's going to happen. That third type of patient is a heart failure patient, right? Heart failure patients have what's called Cheyne-Stokes respirations or Cheyne-Stokes breathing. That's where they have really shallow breaths. It gets bigger, 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 stop. And they repeat that all through the night. Now, you all know there's a contraindication for ASV, which is another reason people are scared of it, because it's just a misunderstanding. If that patient has preserved ejection fraction, or if they fit in one of those three categories, that's the right therapy for them. ASV is an algorithm. Again, one of those other terms that I'm sure we've all heard today in some of these other sessions. Think of your car, think of your cruise control. Guess what cruise control is using? It's using an algorithm. You're telling your car to set at 70 miles an hour. It's probably faster, I know, but I'm going to say 70. So 70 miles an hour, right? And what does your car do when it starts to go up a hill? The accelerator goes down and you go up the hill. When you go down the hill, it comes the other way and backs off, right? It's using a set of rules or what you told it. Think of ASV like that. ASV is using a set of rules that you determine when you put those settings in the device, and it's going to treat the patient accordingly. But it's only looking, and again, learn this with your manufacturers. One manufacturer uses what's called peak flow, which is the peak like the top of the mountain. Every breath has a peak. So peak flow is the top of that mountain each breath, and it's measuring that over a 4-minute moving window. One of the manufacturers uses a 3-minute moving window and looks at that minute ventilation that we talked about earlier. Rate times volume of air per breath is minute ventilation. It's only targeting 90% of that patient's most recent minute ventilation. Because remember, these CSA patients don't have CSA during the day. They have CSA at night because of their CO2 levels dropping. So we are not trying to provide, or we're not trying to ventilate these patients like we would a COPD patient or an obesity hypoventilation syndrome patient. What we're trying to do is stabilize them. So if I have a COPD patient or a neuromuscular patient in my lab and I put them on ASV, will ASV work for them? The answer is no. It absolutely will not. Here's my soapbox. Is it possible for a patient with hypoventilation, COPD, neuromuscular, is it possible for them to also have central apnea? 100%. But if you put them on ASV, they will fail if they have hypoventilation. That is not the right patient. And unfortunately, in my experience, kind of across, I've had the good ability to travel many states and see it applied incorrectly. It will not work. It will fail every time. It's not the device. It's that we didn't put the patient on the right therapy at the right time. If you don't remember anything else today, remember ASV therapy is not for someone that has hypoventilation. If they do, it is not the right therapy. Never go there, please. Those patients can be treated on a volume-assured pressure support mode. So this is a neat mode. This was a mode, to be honest with you, I don't know who had it first, but it's a brilliant mode of ventilation. It is a mode of ventilation that uses adjustable pressure support and an algorithm. So again, I give it a set of rules. I say, Nelda is an old friend of mine. I used to be the Fisher & Paykel rep in Tennessee. So Nelda and I go back a few years. And so I'll use Nelda, okay, as an example. Nelda is trim, slim, female. Her tidal volume might be 350. So what I do is I tell the algorithm or this device, I want to ensure that Nelda's tidal volume on every breath, machine breath, spontaneous breath, hopefully she won't need a machine breath, because if I support her own breathing at 350 a breath, hopefully she'll have what she needs. So volume assured pressure support mode, and that algorithm is just saying, I'm going to give Nelda 350 cc's every breath. I'm going to ensure or assure that all night long. Now, here's the difference. If I put her on a spontaneous bilevel, just IPAP over EPAP, remember I said maybe 1 centimeter might be 50 cc's, but there's no way to know that. There's no assurance at that. So if I put her on a IPAP of 10 and an EPAP of 4, I have a pressure support of 6, that doesn't mean she's going to get 300 cc's of air of your breath. There's no way to do that because it doesn't take into account a couple of things. What do you think one of those things might be? Body position. I'm sorry, I interrupted somebody. Yeah, exactly. It doesn't take into account, and I don't know this about that, but I don't. Maybe she had a cocktail. I don't know that, but maybe she did. Right? That changes the way we sleep. Maybe she props up on 3 pillows tonight. Maybe she had 1 pillow last night. I don't know. Maybe she rolls over on her back. All of those things are things that can't be controlled, and you cannot control with just a standard bilevel. You need to assure that that patient is going to have a volume with each and every breath, and that's what volume assured pressure support does. It's really not that scary. It's pretty darn simple. ASV and IVAPs are just like setting cruise control on your car when you know what you're doing. How many of you in here use cruise control? Raise your hand. Most people, right, use cruise control if the conditions are right. But very few people use volume assured pressure support modes or ASV because we don't really know how to operate them. And I'm not going to solve that today, I know, but I hope I'm giving you something to think about. How might I help these patients who are coming into my lab that are more complex? I'm going to spend more time with them than anybody else is. And I know at the end of the day, I know what you guys want to do. You want these patients to be successful. Again, a lot of it's out of our hands. But what can we control? And those are some things I think that we can control. So again, these are just the titration guidelines. Pretty simple. You know, nothing. The reason I put this slide in there as a placeholder was this. What I'm talking about, right? You must be sure that whatever you're doing, following your lab's protocols and your medical director's protocols. At the end of the day, that's the most important thing, right? There are some things to consider, and I want to review those. It's mask fit. Every manufacturer has a different way of looking at leak. There's intentional leak, means that that's the expected leak that happens from the valve on the mask. Whether that be the leak port, whether that be holes in the mask, whatever that is, that's intentional leak. Unintentional leak is a result of the mask coming off the patient's face. Some manufacturers report both. Some manufacturers report just one. It's critical to know that. Here's something else. In your titration equipment, know this, because again, I'm being vanilla, but the one that does the 24 liters per minute, you should go into your titration equipment and tell that titration equipment what kind of mask you're using. You can do that. It doesn't say, it's not specific like this brand, whatever. Is it a full face mask? Is it a nasal mask? Is it a nasal pillow? Have you ever seen a leak reported at 0? Some people have. If you don't set that in your titration equipment, you will not have accurate leak reporting. Because if the device is expecting a certain amount of leak to be happening, and there's a bigger leak from a full face mask than a nasal pillow mask, agree? So if I set the device up and say I've got a nasal pillow mask, but I really have a full face mask, I might have a leak that says 0. That's not what we want. We want to be accurate, because those two devices that I talked about that use that set of rules, if it's not accurate, then it will make your night rough. It'll make your patient's night rough. You want accurate leak reporting because those devices depend on leak being under control. The manufacturer that uses that intentional leak reporting only at 24 liters a minute, once you get above 30, that algorithm, it's like all of a sudden now your car thinks, okay, well, you told me to go 90. But you didn't. You sure don't want to pass this. If I remember from living in Tennessee, you don't want to pass Tennessee Highway Patrol doing 90 and 70. I don't, anyway. It's a bad thing, right? So same thing with your patients. If you don't set that expectation, these devices don't know where to go. So that's what we're looking at, okay? I'm almost to the end here. So what you're looking at top in my, unfortunately my automation didn't work, but this is a patient, don't pay attention to the epic actually, but look at the top. That's a histogram of sleep. This is a patient that was titrated on CPAP, then bilevel, and then went back to CPAP. Anybody guess the area where they were titrated on bilevel? This is the sleep, where it was consolidated. So that third area right there is the patient was being treated on bilevel. They were sleeping. They went back to CPAP, and they had a lot of awakenings again. Synchrony settings. Again, ask your manufacturers about those. Your manufacturers in those guides should have just a guideline to kind of help you understand where should I set some of those synchrony settings, that trigger, cycle, etc. Where can I set those for different patients? And of course, we talked a lot about solutions, and we talked about smart apps and patient on phone and all this stuff. All of that stuff does work better together. We're getting better. We're getting better tools. And then this is my final slide. How long do I have left? I can't really see it. I don't. Oh my Lord. My friends back there, I didn't see you raise your hand. I'm sorry. Okay. You guys are great. Real quickly, National Highway Transportation and Safety Administration in 2022 reported 100,000 accidents related to drowsy driving, resulted in 7,000 injuries and 1,550 deaths, $12.5 billion worth of losses, property losses, losses of insurance, lawsuits, etc. This is a Jackson Sun. I'll do this real quickly, I promise. This was my family. One of my family members was driving drowsy, coming to my house in Nashville. Fell asleep at the wheel, killed a 31-year-old driver, single mother of another vehicle as he crossed across and landed on top of her. They were in a passenger tank, Mercury Grand Marquis. Ever seen one of those? Holy cow. He was not wearing a seatbelt. He went out over across my mother, landed in the highway where an 18-wheeler tried to avoid the accident and ran over him. And that's what my mother saw. Physically, she was okay. But here's the point I want to make. It was my mom's new husband. My dad had passed away. She'd remarried. He was a CPAP patient. I knew he was struggling. I said, put that CPAP in the car and bring it to my house. We'll see what we can do. My mom, all she could think about was going to find the stuff that was in the car because it was Christmas. She had stuff, you know. She'd come to see her baby boy. She fixed biscuits or whatever she did, you know. I went to clean out that car, even went to the accident site. Anyone want to guess what I didn't find? The CPAP wasn't there, folks. We make a difference every day in what we do. Thank you all for that. Because I don't want anybody else to have to experience what my family and what an innocent person, 2 young boys are now growing up without a mother because he drove drowsy. I don't know if he was on the right therapy or not, but he was non-compliant. Thank you all so much.